Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone. Today, inshallah, we are going to have a simple clinical approach to management of a case of hirsutism. When I say hirsutism, I don't mean hypertrichosis. Hypertrichosis is the non-androgenic distribution of hair, which may be excessive than normal because of medical reasons or endocrinal reasons. But hirsutism mainly is androgenic distribution of hair in a female. And this is typically a tool to predict hyperandrogenism, plus or minus acne, male pattern hair loss, and oily skin, changes in body shape. But the main sign that is going to be associated with hirsutism is menstrual irregularities. And we are talking today about terminal hair. Terminal hair is long hair, pigmented hair, make up the hair of the eyebrows, the scalp, the axillary, and pubic areas, not the lanugo or vellus hair. So hirsutism here can be divided into androgenic causes, non-androgenic causes, and idiopathic causes. In our practice, guys, we mainly focus on excluding the most dangerous causes, and then it could be anything else. So bear with me until we talk about the causes. I need to have a quick evaluation for my case. Through the history, I'm going to know if this patient is having history of any drug intake. That could be the reason. Changes in her weight or facial contour, the presence of other factors that could be a lead for hyperandrogenism, like the acne, the hair loss, the balding, and definitely the menstrual and reproductive history. Not to mention that we need to do physical examination, mainly to have a score. This score is called Ferriman-Galway scoring. This score is going to depend on the presence of hair in different body areas. And as you can see, we are going to consider a diagnosis of hirsutism when we have a score of 8 or more, okay? Not also to forget that the onset, course, and duration of this appearance of hair is very, very important, guys. Because if we are talking about new onset, worsening hyperandrogenism, which is hirsutism also, this could need the exclusion of androgen-secreting tumors. And if the patient is postmenopausal, I'm going to think about ovarian hypertrichosis. But if it's something like gradual, it's taking forever, it's increasing by time, it's progressive but not acute, okay? I'm going to think about mainly the ovarian causes, and after excluding it, I'm going to think about the androgenic causes, but of course, non-malignant. Okay, the hormonal profile is going to be my tool to diagnose the hyperandrogenism. So I'm looking for total testosterone, I'm looking for sex hormone binding globulin, and I have a test that combines both of them, which is the recommended test in our college, in the RCOG. We are going to do what's called free androgen index. The free androgen index is going to calculate both of them, the total testosterone divided by the sex hormone binding globulin. If this is high, and let's be very specific, if it's more than 5 nanomole per liter, I'm going to complete my road to exclude androgen-secreting tumors and non-classical CAH. Of course, we are talking here about an adult lady. I'm not talking about a small lady. So if I'm talking about someone who is having irregular menses, and now she's having hirsutism, she's having other signs of hyperandrogenism, and she is having a high free androgen index, I'm going on with, let's say, excluding androgen causes like androgen hormone producing pathologies, okay, and of course androgen secreting tumors. We could think about doing the deoxycortisol, for example. If from the physical examination you are suspecting that this has something to do with Cushing syndrome. So yeah, okay, I'm going to do the deoxycortisol, and we can do the cortisol in the morning and in the evening, okay, to diagnose Cushing syndrome. Of course, we can also use 17-hydroxyprogesterone to diagnose, yes, exactly, the non-classical CAH. Yes, so 17-hydroxyprogesterone is our key to diagnose what's called the adult onset or late onset congenital adrenal hyperplasia, which looks the same as PCO. PCO could give us some signs and symptoms. Late onset CAH is going to give us the same signs and symptoms. But in PCO, the free androgen index is going to be 5 or less, and mainly less than 5. In case of androgen-secreting tumors and late onset CAH, the free androgen index is going to be more than 5. The H-ray is telling us that the DHEA levels are not in a great value because sometimes they are not reflecting the real adrenal state in this woman. Why so? Because they are not very specific and they are really influenced by the age. So the greater the age, the more the decrease in the level of DHEA. So I don't really recommend that. This could be a routine test. And also they do not recommend doing the serum androstenedione or DHEA levels in patients with Hirsutism because it's not going to be of a great value. Okay. Next would be, if I have excluded all those, if everything else is normal, I could think of something that is not androgenic, like prolactin, like thyroid dysfunction, plus or minus cortisol, of course. I'm going to do adjuvant ultrasound evaluation to solidify my diagnosis. Okay, so ultrasound is going to be helpful, but it's not a routine tool also in the management of Hirsutism. Unless you need to know whether this is ovarian mass or ovarian cyst or what's going wrong with the patient ovary, okay. Otherwise, if you have a clear diagnosis from the investigations and from physical examination, you don't need to go through the ultrasound evaluation. However, you still need to know the features of the IOTA group, the International Ovarian Tumor Analysis Group. This is very helpful in your practice. This is very sensitive, up to 95% sensitivity and 91% specificity. We have features for benign ovarian cysts and features of malignant cancerous ovarian cysts, and we have a score. Okay, you might have heard about the IOTA score, and we apply to know if the cyst the patient is having is predicting for a malignant tumor, or it is predicting for a benign tumor, or even a simple cyst. Okay, and you have here what we mean about unilocular, solid, multilocular, and so on. I got you the IOTA terms to make it simpler for you. Now let's go back to go in depth with the causes. And you know, mainly in the exam, they are going to bring you a scenario and ask you about the best next step. And the most important differential diagnosis in Hirsutism in our practice would be, yes, exactly, the PCO versus the late onset congenital adrenal hyperplasia, especially if I'm talking about a perimenopausal or premenopausal lady. She's not postmenopausal yet. So having a ovarian tumor is not really common. Having ovarian hypertrichosis is not common. And more commonly, she's going to have a problem with her ovary or her adrenal in a benign way. So the PCO, we know for sure that we have a criteria to diagnose PCO. This criteria, or the Rotterdam criteria, is really useful in diagnosing PCO. And yet, we cannot diagnose PCO depending on a single feature. We have to do the combination of features. Okay? So, according to the Rotterdam criteria, and I'm going to stress over some points here. Okay, so please make your notes, take your notes. First of all, I need a woman with oligo-ovulation or anovulation, clinical hyperandrogenism, and biochemical hyperandrogenism, unilateral or bilateral polycystic ovary on pelvic scan, and we have a cutoff. The ovarian volume should be 10 centimeter cube or more, or elevated anti-Mullerian hormone in adults. And of course, after exclusion of less common hormonal pathology. Those are the main 4 criteria in the Rotterdam criteria. I need to have at least 2 of those 4. The fourth one is a must. So between those 3, we need to have 2. And take care, guys. I can depend only on clinical hyperandrogenism. Having biochemical evidence of hyperandrogenism is, of course, an important addition in my diagnosis, but it's not a must if I'm having a clear clinical hyperandrogenism. Okay? If I'm having oligoovulation or anovulation plus clinical hyperandrogenism, I don't need to have the ultrasound criteria. And this is very important according to the ESHRE 2023 guideline. Ultrasound is not required to confirm the diagnosis in women presenting with irregular cycles and clinical or biochemical hyperandrogenism. Moreover, the AMH levels are not recommended in adolescents. So if we are having a case of adolescent, and this lady is having now irregularities in the menses, and she's having hirsutism already, AMH is not useful in her case. The polycystic ovarian morphology should not be used for diagnosis of PCO in adolescents also. Why so? Because, guys, ovary is yet to reach its peak maturity. So maybe she's going to have the small cyst, the primordial cyst, okay, all over her ovaries, and you might think that this is PCO. It's not PCO. So within 8 years of menarche, if you find a patient coming to you and her first menarche was just 7 years, 6 years, 5 years ago, you shouldn't have the polycystic ovarian morphology within your diagnosis. And I have seen this too much, okay? This is going to lead to overdiagnosis of PCO in adolescents. So please depend on the Rotterdam criteria. Please think that you don't need both clinical and biochemical, this and this or this. And don't use the PCO morphology on the pelvic scan for adolescents. Don't use the AMH for adolescents. And if you are having clear clinical diagnosis plus clinical hyperandrogenism or irregularities and or biochemical hyperandrogenism, you don't need the ultrasound. This is for the PCO so far. And if you have excluded everything else, now you can finalize the diagnosis of PCO. We have next the androgen-secreting tumors, which we need to exclude specifically in cases of recent onset, very progressive, very rapid presence of hyperandrogenism. Not only this, if she is having virilizing symptoms, this patient is not only having a small rise in testosterone, we are talking about huge number of testosterone levels. Virilizing symptoms are totally different from hyperandrogenism symptoms. Virilizing symptoms mean clitorimegaly, voice hoarseness or voice change, male muscle distribution, breast involution. So I'm talking about something really big. This is mostly androgen-secreting tumor, whether it was adrenal or ovarian. So again, age. Don't forget about age. Am I dealing with adolescent or a patient in her peak reproductive age? Or I'm talking about someone who is perimenopausal or menopausal? It's totally going to change your route for differential diagnosis. You can go for MRI or CT for the adrenals or the ovaries if needed, okay? If other investigations like the ultrasound or the total testosterone levels are not really conclusive. Take care that sometimes ovarian tumors are very tricky. Androgen-secreting ovarian tumors, they are really small in the ultrasound sometimes, and they don't really appear this easy. And they are not giving huge number of testosterone in some cases, okay? Some cases they are not going to give huge number of testosterone, like Sertoli cell tumor, for example. Sometimes it gives a slightly rise of testosterone levels. So it's not going to be easy to diagnose. You have to put everything on the table and search for the cause. So when you have persistent, substantial increase in total testosterone, this is not normal. This prompts investigation for adrenal or ovarian tumors. Even if it's not really high, only having total testosterone level more than twice the normal level should prompt investigation for tumors. The most important differential diagnosis in our practice also, which mimic the PCO, is the late onset CAH. This is going to happen because of the enzyme defect. And this enzyme defect, which is the 21-hydroxylase deficiency, it's not like the early onset or the typical CAH. The typical CAH is going to appear after the baby female has been born. But this late onset or atypical CAH is going to appear mainly after puberty. The result is going to be elevated levels of 17-hydroxyprogesterone. 17-hydroxyprogesterone is androgenic, and this is why this patient is going to have hirsutism and signs and symptoms of hyperandrogenism. More common, of course, in young women. I just told you, just after puberty, and she's now in the peak of her reproductive age. Ovarian hypertrichosis is something to look for during postmenopausal years. It can happen in premenopausal year, but it's not that common. This patient is going to have rapid onset hirsutism worsening badly virilization, obesity, and insulin resistance also. The reason why she's having ovarian hypertrichosis is the overproduction of gonadotropins like LH. And this is by far the most accepted theory, but this elevated LH is going to do what? It's going to stimulate the ovarian stromal cell to differentiate into theca cell. Theca cell are the main ovarian source of androgen. So again, this lady is going to have hirsutism, virilization. Moreover, they are not only linked to virilization and hirsutism, but also to metabolic abnormalities like obesity and insulin resistance and the risk of endometrial hyperplasia. You would say, how endometrial hyperplasia? Because please always remember that when you have a large amount of androgens in the system of any of us, this could lead to peripheral conversion of testosterone to estrogen in peripheral cells. Okay, so this woman is not only at risk for having complications like virilization or hirsutism. No, I'm talking about metabolic complications. I'm talking about risk of endometrial hyperplasia. So diagnosing it and the treatment of ovarian hypertrichosis is also very important for her health in general, not only cosmetically. Other causes is going to be treated as well if it was prolactin or drug-induced or whatever. But we have something that is not really common. It's only 3% of women with androgen excess, which is called hyperandrogenic insulin-resistant acanthosis nigricans syndrome. This is going to happen with people who are having extremely high levels of insulin, severe state of insulin resistance. So those ladies are going to have a state of hyperandrogenism, insulin resistance, of course, and moreover, they are going to have acanthosis nigricans as a dermatology symptom. So those who are severely hyperandrogenic, and sometimes it could be up to the level of signs of virilization. They are really difficult to treat. Their problem is really complex, and of course, they are going to have multiple comorbidities and also metabolic syndrome. So for those ladies, we are going to offer some drugs. We can offer, of course, changing of her lifestyle and healthy lifestyle and so on. But take care, please, that some drugs that they could be taking could be the cause also that increase the state of hirsutism in those ladies. For non-androgenic factors, we mainly talked about the iatrogenic or drug-induced. We have also idiopathic causes. Idiopathic causes could be up to 50%. So if I have excluded everything, and specifically in someone who is having only hirsutism, there is no irregularities in menses, the ovary is looking normal, no evidence of adrenal or ovarian tumor, this is idiopathic hirsutism. But you are not going to exclude this unless you have excluded or ruled out all other dangerous differential diagnoses. If we focus on the androgen-secreting tumors, I just need you to remember that those cause of hirsutism and virilization are going to have some clues in the exam. The first one is the clinical history of rapid progression of symptoms, presence of virilization. Some of them can be having cushingoid features also. Best way to diagnose androgen-secreting tumor is clinical presentation. Remember when I told you that sometimes Some ovarian tumors, androgen-secreting ovarian tumors, are going to be very tricky to diagnose because they don't give us high levels of androgens. And also, some biochemical markers like suppression or stimulation tests could be misleading with those types of tumors. So think about it when you think about diagnosing those types of tumor in the exam. Just having the word of rapid excessive hirsutism or signs of virilization is enough for you to exclude androgen-secreting tumor. This could be ovarian or adrenal. Virilizing tumors, which is famous in the ovary, are the Sertoli Leydig cell tumors. Those tumors, guys, are not common. They are rare sex cord gonadal stromal tumors. Those virilizing tumors mostly are going to be Leydig or granulosa cells or leutomas, or they could be Sertoli Leydig cell tumor. So Leydig cell tumors are two parts. They are not only one kind. They could be Leydig cell tumor only, or Sertoli cells only, or a combination of both of them. And this is why they are having different signs and symptoms among literatures. You have to be alert for what type of tumor exactly the paper or the website or the book is talking about. Some books and some literatures are speaking in general. So this is why I'm telling you, in the exam, we are not going to depend mainly on the biochemical investigations. We are going to depend on the clinical examination. Sex cord ovarian cancers usually happen in young women, but again, they can happen at any age. While if the tumor is composed only of Leydig cells, those are more commonly to be seen in postmenopausal women. So this is why I'm telling you, it's not really specific in some literatures. And this is why there are so many conflicts about the type or the nature of the Sertoli Leydig cell tumor, how it appears, how it looks like, how it's going to be presented in the woman. You are going to find some papers talking about this rare tumor as a case study, okay, in postmenopausal women, while we are saying here that it is mostly observed in postmenopausal women. Yes, when it's combined, like Sertoli Leydig cell tumor, this is rare to be seen in a postmenopausal woman. Okay, so just take care of the histopathology of the cancer. They are by far going to cause virilization and hirsutism in 75% of cases. If it happens in a young patient, this could lead to precocious pseudopuberty. Okay, so this is also an important differential diagnosis. Mainly, they are going to appear as a unilateral solid tumor. But they can be bilateral? Yes, they can. And we have some case studies talking about bilateral Sertoli Leydig cell tumor, which is very, very rare. Okay, those tumors almost benign. They are not malignant. So just removing the tumor or the ovary is going to be a cure. You don't need an extensive pelvic clearance or anything. Okay, so far we have talked about all the causes that we have for hyperandrogenism and hirsutism. At the very end, we are going to talk about the management. Management is going to depend on what the patient wants. Does the patient want something to treat the hair cosmology, or she's seeking something related to fertility? She needs something to do with the irregularities of her menses. This is very, very important to know before determining a plan for the treatment. So, of course, after lifestyle modification and cosmetic procedure, with whether it was going to be laser or creams or whatever, if she is seeking fertility, we can delay the drug treatment because mostly they are going to be teratogenic. If she's not seeking fertility and she is okay with taking the COCs, we can give her COCs that contain anti-androgens, right? Or we can give her anti-androgens plus COCs or any kind of contraceptions, okay? If she is okay to take the COC, we are going to give her something that contain sapropterin or drospirenone or neutral progestin. We can also, in case of severe hirsutism, add finasteride or spironolactone. Again, in our exam, they don't mainly ask about cosmology, of course, or the cosmetic procedures. They mainly want you to know how to treat the PCO. They want you to know what types of COC are containing anti-androgens. If she cannot take COCs as a formulation of COCs, like for example, she is contraindicated to take estrogen, we can give her the anti-androgens alone. And of course, we are going to give her any other type of contraception because those are teratogenic. And they are very dangerous if she is having a male boy also. At the end of this file, you are going to find some algorithm and flowcharts to summarize all what we have talked about, according to the onset, according to the cause, and finally, according to the clinical history and physical examination. It's really helpful to sum up everything. And here, this is the flowchart, not mine. This is from the RCOG and the ESHRI. So again, guys, I'm going to consider in my diagnosis onset, duration, the course of hirsutism, the patient age. Very important to know if there is any virilizing symptom or not. She's menopausal or not. If there are any signs or symptoms for abdominal or pelvic mass that is going to make me think that, yeah, I'm dealing with adrenal or ovarian tumor. And of course, if they told me in the scenario anything about ultrasound features. Not to forget that when you are having elevated 17-hydroxyprogesterone more than 200, this is mostly late onset adrenal hyperplasia. Don't think about ordering androstenedione or DHEA. However, if you are having in the scenario high androstenedione, while the DHEA is normal, this is mainly PCO. I hope we have gone through a simple approach. I needed to go through also the approach for diagnosing a case of hyperandrogenism. Let me show it to you, which depend mainly on the RCOG guideline in how to diagnose a case with hyperandrogenism according to the physical signs, of course, and recommending the free androgen index. And according to the result of pre-androgen index, we are going either or. We are talking here mainly about someone that we have excluded other causes from the clinical examination, like she's not having a prolactin issue, she's not having thyroid issue, or she's not having cochinoid features. I'm thinking only of a pure case of hyperandrogenism. If you are having signs of virilization or the free androgen index is greater than 5, you have to exclude androgen-secreting tumors and the late onset CEH. How to do this? By doing the 17-hydroxyprogesterone measured in the follicular phase. If it's greater than 200, this is by far non-classical. If it's borderline, and I'm not really sure, and the signs and symptoms are not really suggestive for adrenal secreting tumors, I can confirm this by ACTH stimulation test. The ACTH stimulation test is totally diagnostic for congenital adrenal hyperplasia. That's all. Thank you so much for paying attention. See you next time. Take care, everyone. Salaam alaikum.